Okay everyone, welcome to my presentation on fungal infections. What we're going to look at today is the plethora of fungal infections in human, from the very minor to the very serious. And I think the best way to start is by splitting fungal infections into the two different types. So basically, on one hand, you have the ones that are commonly seen in all forms of pharmacy, which are the peripheral fungal infections. Okay, and they're things like athlete's foot. Okay, you can also have tinea infections such as ringworm. You can also have candidiasis, okay, oral or vulvovaginal thrush. Whereas on the other half, you have what are known as the systemic fungal infections. Okay, and these are really an invention of the late 20th century. The reason being is that there's a multitude of pathogenic fungi in the world. However, actually, they very often do not infect humans, and it tends to be only certain classes of patients that get fungal infections, especially the systemic ones. Okay, and those are patients who are immunocompromised. Okay, and the plethora of patients with immunocompromisation has really increased in the past 50 years or so, and that's because of things like HIV infection, transplant medication, okay, and also the large amount of autoimmune drugs, okay, that actually suppress the immune system. So drugs for rheumatoid arthritis, Crohn's disease, the infliximabs, the rituximabs of this world all affect the immune system. So that tends to be the two major divisions in the clinical presenting symptoms of the disease. Okay. So fungi tend to take two main forms when they grow. They can either grow as yeasts or moulds, and my Christmas dinner here from last year shows both quite effectively. So up on the right you have your stereotypical kind of fungal growth that you get on cheese or any food that you leave from last year. Okay, and that is a mould. Okay, and the common species that cause mould infections are Aspergillus in humans. Okay, whereas this nice like kind of colony forming unit here is a yeast. Okay, and the main difference between the two is that moulds reproduce by producing hyphae, which are the sort of furry kind of hair-like projections which go out of the cells. They go somewhere else, they can form spores, they can land somewhere else, and they can grow if the conditions are right. Whereas yeasts here, the yellow ones, tend to split in the same manner as bacteria. And they, reproduce by either budding or mitosis. Okay, and that has effects on which antifungal agent you choose to use in an infection. Okay, common yeast species are Candida, whereas common mould species are Aspergillus. Now you really have to remember when you're thinking about fungal infections is that fungi are actually eukaryotes, they're not prokaryotes like bacteria. So because of that, we have fewer targets to actually attack fungi with, and especially in systemic infections that causes problems because fungi are eukaryotes. Okay, the drugs that we actually use to treat fungal infections can be more toxic, okay, because they target things which are similar to cellular components in humans themselves, because they're both eukaryotes. Okay, so we're going to actually look at some fungal diseases now, and we're going to look at some peripheral ones to start with and see what we can do. So here we are. These are all very similar conditions actually. Okay, so top left is athlete's foot, top right is ringworm, bottom right is what's known as tinea capitis, okay, or a fungal infection of the scalp. Okay, these three diseases can be quite debilitating but can easily be treated in the pharmacy. Okay, so for instance, for athlete's foot you may use Dactarin powder or miconazole. Okay, and that could also be used for the fungal infection of the skin, which is also known as tinea corporis or ringworm. Okay, so that stereotypically presents in this manner when you have a red ring surrounded by a white kind of area, and it's basically the way the fungus grows as it grows out towards the surrounding part of the fungus itself, causing a characteristic ring shape. Again, you could use miconazole to treat that, just the normal topical cream. You could also use clotrimazole if you wanted to. Any of the azole creams could be used to treat that. Often you can also use something called terbinafine as well. However, that's normally reserved as second line for treatment. Okay, the reason being is terbinafine is fungicidal, okay, rather than fungistatic. So normally they'll use the miconazole and allow your skin to recover, or another azole. However, if that doesn't work, then you can use terbinafine or Lamisil cream. Okay. Okay, so on the bottom right here we have tinea capitis, okay, which is a fungal infection of the scalp. Okay, and it has caused hair loss in this patient here. Can commonly see it. It's normally an overproliferation. Often, best thing to use is either ketoconazole or selenium shampoos for these conditions. Okay, and they'll often resolve after a few weeks of treatment. On the bottom left is a slightly different condition, alright? This is known as pityriasis versicolor or tinea versicolor, okay? And that basically is characterised by the discoloration of the skin. Again, a ketoconazole body wash can be used for the disease itself. And that may lead to an improvement in the appearance of the skin. However, sometimes scarring can be permanent in this condition. So these are all quite common things that you can see and treat in your pharmacy, and you may wish to, counter-prescribe or respond to symptoms in those ways. Okay, very often creams can be used for that. Okay, however, you can get quite serious conditions, and this is known as either tinea barbier or psychosis barbier. Okay, and this is a fungal infection of the hair follicles in a man's beard. Okay, it tends to affect Afro-Caribbean patients rather than white patients normally. Okay, and this, if you actually saw this in your pharmacy, I can actually, looking at it here, you've got these kind of yellow nodules. I think that would be a cause for referral to a GP, because you may think there's actually, rather than just a fungal infection there may be some bacterial involvement, and they may need to prescribe a local antibiotic such as fusidin gel. If it was just fungal, then miconazole, clotrimazole or terbinafine would all be options to treat it if it was a simple fungal infection. But in that case, I would definitely refer to the GP, okay, because there may be an underlying reason why the infection has become so severe in that patient. Okay, now then, these lovely things here, can you guess what these are? These are candidiasis infections caused by the Candida yeast. Okay, most common cause of thrush in a patient. So on the left we have oral candidiasis, on the right is actually esophageal candidiasis, and that could definitely happen as a consequence of the left. So this is why you tell patients to wash their mouth out after they've taken their steroid inhalers. You don't want people getting oral candidiasis. Okay, there's a few other associations, so they can be caused by antibiotics as well. Okay, but often it's more immunosuppressants or corticosteroids that tend to cause these infections. Fairly treatable, over the counter. Okay, in the case of the one on the left, you could give miconazole oral gel, okay, or dactarin oral gel. However, probably you'd actually want to prescribe something, and then you can use nystatin suspension. Nystatin is a polyene antifungal. Okay, it's not absorbed orally whatsoever, and it's actually very effective for treating candida infections as well. One thing I haven't shown you a picture of here, but is a very common complaint, is vulvovaginal candidiasis. Okay, often referred to as feminine itching. One of the most common presenting symptoms in a community pharmacy, actually. Okay, and there's actually a lot of treatment options that we have. Normally, probably the original kind of cream that you would use would be a clotrimazole cream for candida infections. However, they can be treated with any antifungal actually, and there are plethora of combination products, okay, on the market, and they're really important to know, very important to know, okay. So for vulvovaginal conditions, you've probably all heard of Canesten Combi, and that can come as a pessary and cream, or two creams, okay, an internal and external cream, or it can come as a tablet of oral fluconazole, okay, 150 milligrams, and the cream. Okay, and the idea behind these combination products is it's not normally the external genitalia that's only affected by candidiasis. The infection normally stretches up quite deep into the vagina itself. Okay, so you need something that actually gets to those parts. So the tablet oral absorption will actually treat the vaginal candidiasis. Okay, or you can have what's known as an internal cream, which is applied locally to inside the vagina itself, or you can use a pessary. Depends on patient preference as to which one they would like, but all are reasonable treatments for vulvovaginal candidiasis. Okay. Okay, so the last little beastie you'll get here is this this kind of infection, which is otherwise known as onychomycosis, okay, or fungal nail infection. It will be known to your patients. Okay, basically it's very often caused by trichophyton species, similar to ringworm, tinea infections, or anything of that nature. And there's a few treatments available in the pharmacy. There's amylorphine nail lacquer, okay, and you can treat a patient if they have up to 2 toenails infected or fingernails, okay. Not licensed for use in diabetics. You normally have to refer them to your GP, okay. And basically, you know, treatment tends to take almost up to a year because it takes the amount of time for the nail bed to grow out and get rid of the infection. So patients have to be persistent, and you actually have to inform them and counsel them on how to use the nail lacquer, okay. So that's basically a nail lacquer. A lot of patients will actually be referred to their GP, and they may use what are known as terbinafine tablets, okay. So similar to what's known as Lamisil in cream form, terbinafine can be given orally. It's quite useful, but again, it can take from 3 to 6 months to actually treat the disease itself. So very difficult to eradicate fungal nail infections. Much more common in diabetic patients as well, because they're a class of patient that's more prone to infection. Okay, so that concludes my whistle-stop tour of peripheral infections that you may encounter in a pharmacy. Okay, but what about severe disease, okay, or systemic infections? What sort of, we've already kind of discussed what sort of patients we get them in. So you're going to look at your immunocompromised patients, so patients with transplant, patients with HIV, okay, patients on immunosuppressants for autoimmune diseases. Okay, so that can be anything from rheumatoid arthritis, okay, to anti-cancer agents, so patients with cancer as well are at increased risk of severe disease. Okay, they're the patients that get the diseases, but what are the diseases? Okay, so you can get a combination of yeasts and molds, so you can get what's known as aspergillosis, okay, which is caused by aspergillus, and that's a lung infection, okay. You can get cryptococcal meningitis, again, much more common in patients who are immunocompromised, okay. And you can get systemic Candida infections, okay, candidiasis, okay. Sorry, I spelled that wrong there. I'm not going to clear it up though. Adds to the mix. So you can get these severe diseases, okay. So what treatments do we have? Well, as I said, treatments are actually quite toxic. Alright, the reason being is that fungi eukaryotes are very similar to human cells itself. So we have a few, okay. We have the azoles, okay, which are probably the most common agents used, okay, and they're such as fluconazole, itraconazole, okay, are probably the two most common agents there. Very useful, and they're some of the least toxic of the antifungals, okay, can be given orally or IV, okay. The problem with azoles is there's a big risk of drug interactions, okay, because they're metabolized by cytochrome P450 enzymes, okay, specifically 3A4, 2C9 and 2C19, okay. And they basically work by inhibiting the conversion of lanosterol to ergosterol in the fungal cell membrane. Okay, so fungal cells are stabilised by ergosterol, whereas human cells are stabilised by cholesterol. Okay, so that's a bit of a target for treatment. Quite useful drugs really. Main side effects you have to watch out for are nausea and vomiting. Okay, but also it can transiently raise LFTs. And if they're raised 3 times above the upper limit of normal, then you would actually think about changing the agent. Okay. Next class we can have are polyene antifungals, okay, and they include nystatin and amphotericin. Now, nystatin I've already mentioned, really useful orally because it isn't actually systemically absorbed. The problem when you give it intravenously and it gets into the systemic circulation is it causes a very nasty nephrotoxicity. The way you have to remember this is these are quite toxic molecules because, for instance, amphotericin is a huge molecule. What it actually does is it binds to ergosterol in the cell membrane, okay, and kind of punches holes in it. Okay, it actually disrupts the cell membrane or the cell wall of the fungi, okay, and actually is fungicidal because of that. All right, similar to penicillin with gram-positive bacteria, basically punches holes in the cell membrane. What do you need to know about the polyenes? Well, the main one we use systemically is called amphotericin, okay, and as you would expect, it's quite toxic, okay, because it can also, weakly inhibit cholesterol, so we have to be careful of it. And it comes in various formulations, and there's 3 available in the UK at the present, okay. It's Fungizone, okay, and there's Abalacet, and the last one is Ambizone, okay. And the 2 secondary formulations, okay, are kind of lipid-bound formulations, whereas the first is more a cellular-bound formulation. What you need to know, and why you need to know this, and why it's extremely important, is the doses differ, okay, between the formulations. So the dose for Ambizone and Abalacet tends to be higher than the dose for Fungizone, okay, because the lipid formulations are much less toxic, cause less nephrotoxicity, okay, but consequently require higher doses, okay. The problem happens is if you administer Fungizone at the dose for one of the other formulations, you get serious nephrotoxicity in your patient, and at least 2 patients have actually died in the UK because of that area. Okay, main thing is don't get them mixed up. Another thing you have to do is a test dose, okay, because of the risk of anaphylaxis with amphotericin. So very important that you give that before starting off a big whacking infusion for a patient. Okay. Next one. Okay, next kind of class you have echinocandins, of which there are 3: anidulafungin, caspofungin, and micafungin. Okay, and these tend to work for systemic infections, mainly because they're all only available as intravenous drugs. Okay, so these tend to be for quite life-threatening systemic mycoses. What do you need to know about them? Anidulafungin, okay, has no clinically significant interactions, okay, whereas the other 2 are metabolized by P450 enzymes, Why is that important? Okay, if you've got a patient who is immunocompromised with HIV, you're very much likely to be on some antiretroviral medication, which has a significant amount of interactions with other medications. Anidulafungin would possibly be a echinocandin of choice for those patients. Um, Basically, they all have the same spectrum of action. Okay, they're broadly active against various fungi. Okay, they're much more active against Candida species, so yeast species, than the molds. Okay, so they're fungicidal against Candida, whereas against Aspergillosis they're only fungistatic. So it kind of limits their choice of action for which kind of fungi you would like them to treat. Okay. Another thing that's important to bear in mind is that they cause liver toxicity as well. So similar to the azoles, so if you saw a patient with 3 times above the normal reference range of LFTs on one of these drugs, you'd actually start to consider using a different medication. Okay, 2 quick ones to end with. Okay, flucytosine is a very toxic drug. Okay, the reason being is in fungal cells it's converted to something called 5-fluorouracil, okay, which tends to bind itself in the position of uracil in the genetic makeup of the fungi itself, because of which it has been used as an anti-cancer agent. Okay, so 5-fluorouracil is actually used for lung cancer, for various different kinds of solid tumours, so bowel cancer. And it actually, what it does is it combines with DNA and actually destroys the replication of the cells. Because of that, it tends to attack fast dividing cells, so you may get side effects. And the biggest one with flucytosine is something called agranulocytosis, which basically is a condition where your white blood cells are not produced. Okay, so it's likely that a patient with a fungal infection already is immunocompromised. If you give them flucytosine, it's likely to immunocompromise them further. But it does have its uses. It crosses the blood-brain barrier particularly well. Okay, so often in cryptococcal meningitis it's the treatment of choice, but you always tend to use it in combination because it's quite easy for a fungi to become resistant to flucytosine. Okay, so you normally combine it with amphotericin in cryptococcal meningitis, and that reduces the amount of resistance there. The last one is a pretty old drug, griseofulvin, and basically this drug's been superseded. Okay, you can still use it. You'll see it's indicated in the BNF for onchomycosis or dermatophyte infections. Okay, it's normally rarely used these days because of concerns with toxicity. Okay, so griseofulvin is the last antifungal that you wish to use. Okay, so in conclusion, basically fungal infections can be divided into 2. You have your peripheral infections such as your candidiasis, your athlete's foot, your tinea infections, easily treated in your community pharmacy. Okay, normally you go for local treatment first before systemic. Okay, and in systemic it would always be oral treatment with an agent like terbinafine. Okay, and that would be more for the more difficult candidas to remove or the more difficult onchomycosis infections, so your fungal nail infections, you'd use terbinafine. Sometimes you may see oral fluconazole used. Okay, systemic mycoses, okay, are life-threatening. Okay, and they place a significant burden on the NHS, probably because they're very difficult to treat. It's actually very difficult to culture a fungi. Often it's really very difficult to work out what kind of fungus is causing the infection itself. Okay, the reason systemic and life-threatening, so often you see IV treatment. Okay, problem with antifungal agents is toxicity. Okay, because it's very hard to be selectively toxic to a eukaryotic cell, which is slightly different from the human cells itself. So you see a lot of liver toxicity, agranulocytosis with antifungal medication. Thank you. If you'd like to learn anything more about infections, I would point you in the direction of the directed reading. Thank you very much.